Welcome to the Stronger After Stroke podcast. I'm your host, Rosa Hart, and today I get to interview Dr. Lina Yassine. She is a endocrinologist and diabetes specialist here in Louisville, Kentucky, and serves some of our stroke patients here. And so I'm really excited to get to talk to you about our metabolism and the effect that blood sugar and things like that have on stroke specifically. Can you tell us a little bit about your background and how you came to be working here?
Of course. My name's Lina. The patients sometimes call me the sugar doctor because I'm associated, with sugars and glucose and diabetes. I've actually, worked in Louisville for over 6 years and then moved overseas at a multidisciplinary clinic in Abu Dhabi, where I came back with a broader experience on how to manage patients with diabetes and cardiovascular risk, and happy to help patients here locally in Louisville with diabetes and other metabolic diseases.
Thank you. I appreciate that.
Of course. Thanks, Rosa.
And I love how you look at things from a complete person perspective instead of I'm going to treat this one little section and forget the rest of your body, because that's the experience a lot of people have sometimes. So one reason that this is really important, and we wanted to highlight it on the Stronger After Stroke podcast, is that if you have diabetes, you're twice as likely to have a stroke than if you didn't have diabetes.
Exactly.
And a big way to prevent the strokes from reoccurring is to get that blood sugar under control.
Exactly.
So can you explain to us how diabetes and stroke are interconnected?
So as you mentioned, a patient or a person with diabetes is about 1.5 to 2 times at higher risk of developing a stroke than a patient without diabetes. And what's interesting in these data is that it affects women more who are diabetic. They are even at higher risk than men are. And that's, in contrast to the non-diabetic patients where we see stroke mainly, or not mainly, we see it more commonly maybe in men because of the other risk factors like smoking and all that, which might be higher in men. But, and the interesting thing about stroke and diabetes is that the outcome of a stroke is worse if the diabetes is uncontrolled. So you have 2 patients who have developed a stroke. One of them has well-controlled diabetes, the other doesn't. The one with well-controlled diabetes, their post-stroke outcomes are better. And so don't give up if you have diabetes and say, oh, I'm just going to get a stroke. But work on improving your control, because the post-stroke outcome, return of functional status and, mobility is higher if the blood sugars are well controlled.
And that you're going to probably be less disabled by it.
Exactly. And the strokes that occur from diabetes are 3 kinds, honestly. So there's the atherosclerotic stroke, which is caused by blockages in the blood vessel. That is definitely related to diabetes, because the higher the blood sugar in the blood vessel, the more the predisposition to plaque formation on these blood vessels. So that's one mechanism. The other mechanism is the hemorrhagic stroke. So patients with diabetes are at higher risk of their blood vessels bursting from diabetes, just as we see in their eyes, the retinopathy. We definitely see blood vessel bleeding, and we can see that same thing in the brain, because these blood vessels are very fragile and sensitive blood vessels. They're smaller, and that's what can cause what we call the hemorrhagic strokes. And the third kind of stroke is what we call the embolic strokes, which are a clot that probably started in the heart and moved up to the brain. And these strokes can occur also because diabetics are at higher risk of infections, and they can get, infections on their valves, and that's where these embolic strokes originate, is probably either from the valve or the heart. Also, they are at risk of arrhythmias, and arrhythmias predispose to developing clots in the heart, and then that clot moves up to the brain and causes a stroke.
Wow. So it can trigger a whole lot of different effects in the body. And thank you so much for explaining it. I feel like that was really clear. And could you then talk about the importance of lifestyle changes, such as a high fiber intake and healthy cooking, in managing diabetes as well as preventing a stroke reoccurrence?
Definitely. I spend over half of my encounter with the patients talking about lifestyle, because I know that is, if you have a table with legs, that's the base. Those are the legs. If the table doesn't have legs, it's going to collapse. So if you don't talk about lifestyle, that's what's going to hold the table together, right? The medications are, the top of the table. They're additive, but the base of any treatment involves lifestyle. And, lifestyle involves a multitude of things: smoking cessation, the eating habits, alcohol, exercise, stress reduction. So all of these are important. And it's a lot of information to kind of spill to the patients all at once. So, you talk about goals that are more easily achievable. So if their eating habits, there's one thing that they feel, yes, I can work on that, be it, juice, soft drink, very high carb diet, if we can kind of cut down on that. So definitely lifestyle is the key and the base for treatment of diabetes, blood pressure, cholesterol, stroke, obesity, metabolic risk. That's the basis. And that's where the multidisciplinary approach comes from. And I'm, thankful for Norton that we have diabetes educators, dietitians, weight loss programs, to work on that, because that's the key.
Yeah, and we do offer free nutrition counseling with a registered dietitian for our patients to call through the Norton Neuroscience Resource Center. So if that's something you'd be interested in, they do in-person as well as phone consultations. So feel free to check the show notes and see how you can get connected there. I think a lot of my patients I've heard say over the years, as I've been doing follow-up calls as the stroke navigator, they'll say, I didn't know I had diabetes or high blood pressure or anything until after I had a stroke. And I come out of the hospital and I'm on 5 new medicines. I don't want to take 5 new medicines, even if it's covered by insurance. They're like, I got to take 5 pills a day. But, and so they're like, well, can't I just fix what I'm eating and can't I just exercise more and not have to take these? What would you say to them?
So this is something I commonly hear. Now, to go back to your point, many patients are diagnosed with diabetes after their stroke. About half of the patients who have diabetes are undiagnosed. And so that's why a regular checkup with your primary care physician, which I know also Norton has expanded their pool of primary care physicians, is very important. Now, in regards to medications, there are multiple trials that have looked at the remission of diabetes, like kind of looking at it as if it's cancer. We talk about cancer remission, getting rid of cancer. We have diabetes remission. So there's the diabetes prevention trial that looked at patients who are pre-diabetic. And we know prediabetes leads to diabetes in about 50% of patients within 5 years.
And these are people who are developing insulin resistance?
Exactly, insulin resistance. So you're a pre-diabetic and the data shows that within 5 years, you're going to develop diabetes. What can you do to prevent that? 10% weight loss.
Is that a weight loss of 10% of your body fat?
Yes, of the body weight. Total body weight. So if you're about 200 pounds down to 180,
gotcha.
You decrease your risk of diabetes by over 50%. So metformin is a medication we use commonly in pre-diabetics because we also know that it decreases the risk of diabetes. Metformin was less effective than weight loss in decreasing the risk of diabetes. So if you are already a diabetic, what do you do? I'm already a diabetic. There are also trials on that looked at weight loss and, change in the quality of the food that is being provided. And patients who are already on insulin can be able to get off of insulin. It requires more weight loss than the 10%. It requires 15 to 20% weight loss, but they're able to get off of insulin and maybe just be on 1 pill for diabetes. So, yes, great effect.
And we know that insulin is so expensive and a lot of people have trouble getting insulin. And so if there's a way to reduce
minimize that.
and
Yes.
minimize the need for
Yeah.
insulin, that could transform a lot of people's lives.
And it's just, not just the diabetes, it will have an effect on blood pressure because we know like 5% weight loss can drop your systolic blood pressure, where you can also get off one of the medications. I'm talking in general. I don't want anybody to, think, okay, I've lost 10 pounds, let me get off my medicine.
Please
No,
take your blood pressure and go to
exactly.
your primary
Go
care.
to your primary care. If you start noticing low sugars, dizzy episodes with that weight loss, congratulations on the weight loss, but really check with your physician on how to adjust your medications based on that.
Right. We don't want to go cold turkey on anything, but also we don't want to keep taking medication you don't need because it could take your blood sugar too low or your blood
Exactly.
pressure too low as you're having these healthy changes in your body. So having an open line of communication can really help. One thing I encourage patients to do a lot is use MyChart, which is something that they can send a direct message to their providers on and get an answer without having to wait on hold on the phone.
Yep.
And so that just keeps a good dialogue going and everybody up to date.
Great.
So there are new diabetes medications that are showing heart and kidney protective effects. So how does that impact their role in patient care beyond just managing blood sugar?
Definitely. So, when I initially started training, the focus was mostly on sugar reduction and glucose reduction. And of course, we cared about the blood pressure, the heart, the cholesterol, but the medications we had that sole effect, just blood sugar reduction. And then, not to belabor it, one of the medications that came out, there was maybe a signal towards increased heart risk, and the FDA required that every diabetes medication that comes out afterwards needs to be tested for cardiac risk. And then, lo and behold, all these new medications that have come out, a lot of them decrease the risk of heart attacks, cardiovascular disease, kidney disease, strokes, on top of, weight loss benefit. So these drug companies took it a step forward and started actually studying these medications on patients who had no diabetes and just had kidney disease, no diabetes and just had heart failure. And again, we saw significant benefit from these medications. So, we should be thankful, I guess, for the diabetes community that these medications are now helping patients who are not diabetic, have high blood pressure, stroke, heart disease, kidney failure, and can be used in these patients regardless of the presence of diabetes or not. So transforming.
And one of those newer tools would be continuous glucose monitors that people can wear. That can enhance diabetes management, especially for stroke survivors. So what misconceptions exist about continuous glucose monitors, and how can people benefit from using them consistently?
So if you're a patient who's on insulin and, we don't really change anything in regards to your medications or dose of insulin, the studies have shown that wearing a continuous glucose monitor can decrease your blood sugar and decrease the hemoglobin A1C, which is the marker for diabetes control. So what happens, our patients become more aware of how food affects their sugar, because we're most of the time blinded. You ask patients, do you check your sugars? Yeah, I do. When do you check them? They check them when they're fasting a lot of times, and they check them on the good days when, not Thanksgiving, not Christmas, not birthdays. And so they're blinded to what's going on most of the time. And so with continuous glucose monitoring, they have access to their sugars every minute of the day, 24/7.
In real time.
In real time.
Not looking back on the last 3 months, but how is it now?
And so they have that Chinese takeout and they see their sugar shot up significantly. They recognize that next time I might not eat as much rice and focus on the vegetables, And so it is an eye-opener for them that how the food affects it, how exercise affects it. We have many elderly patients who are living alone. Their perception of low sugar goes down with age, so they are unable to sense a hypoglycemic or a low blood sugar event where, you would get the typical symptoms of heart racing, sweating. Especially in these stroke patients, it is of concern because a low sugar may precipitate a seizure or a subsequent stroke.
Or create stroke-like symptoms that can
exactly.
make you think you're having a new stroke when it could be temporary if you treat the sugar.
So the beauty of these sensors is that it gives you an alert prior to dropping. It tells you you are going down at a fast rate, even though you're still at 90. The sensor anticipates that within 20 minutes, you're going to be low. So you act on it. And the sensor has, arrows that tell you, you're at 100, but I anticipate you're going to be going up. You're at 100, but I anticipate you're going to be down or just staying flat. And these sensors can be linked with family members who are not even living in the same house, that they can get alerts and call their loved one and tell them, I got an alarm that your sugar is low or high. Are you okay? And they can act on it.
Wow. From a safety perspective, that sounds really good to me, because I worry so much about some people who have a life alert button or something that they could press if they were alert to do so or physically able to. So having something call for help for you sounds helpful.
Yes, definitely.
Yeah. Do you encounter any challenges with insurance coverage on these newer medications and equipment? And how do you recommend people navigate that?
Yeah. So we've definitely seen a change in how insurance has now become more lenient on approvals, because we see the benefit, right? And so we look at long-term benefit. If we have a reduction in blood sugars, if we have a reduction of low sugar that requires hospitalization, that's definitely cost cutting on the insurance companies, because one hospitalization is very expensive. So they see that, I think, just with proper documentation and supporting documents to the insurance companies, that this patient is at risk of low sugars, this patient has a high hemoglobin A1C, is on multiple insulin injections, and just having that information for the insurance definitely gets more approvals coming our way.
Well, good. That's hopeful. Could you address the debate around the use of artificial sweeteners in diabetes management and the potential side effects of those?
Yeah. So, I think it was at the Cleveland Clinic Journal that came out with a study that looked at erythritol blood levels in different patients and their risk of stroke, heart attacks, and even death from cardiovascular disease. And they found that erythritol, which is one of the artificial sweeteners that is used, patients who had a higher level were at a higher risk of stroke and heart disease and death from cardiac disease.
But it's being used by people who are trying to avoid high blood sugar in order to prevent all of those things.
So, I talk to my patients a lot about this. A lot of them have issues, with soft drinks, and this might be an alternative that is less sugar or sugar-free. But, I try and focus, let's do water with maybe a squeeze of lemon, flavoring with just putting strawberries in it, or cucumber to give it a little bit more flavor than these artificial sweeteners. Now, there's that association, but we still don't know if it's a cause and effect, right? So that definitely requires more studies. They think that erythritol, or the sweetener, increases the risk of clotting. The platelets, which are the clotting factors in our body, are predisposed to being more sticky with these erythritol products or the sweeteners. So that might be a mechanism that's causing it. So definitely, if we can avoid it, minimize, if you're doing 3 a day, drop it to 1, and then 1 every other day, and then 1 a week. So do it gradually, and hopefully you'll see the benefit of that.
Yeah. And I think that's a pretty consistent theme we have throughout here, is that lifestyle changes are gradual over time. Cold turkey is not something we're pushing for most things. It's generally gradual. And we do have another episode about eating for brain health with a registered dietitian, talking about how to make the most healthy decisions on any budget with the groceries that are available to you, with guidelines from the Mediterranean diet, which has been proven to help with brain health, which aligns with everything you're saying.
Yes.
So there's also a handout that goes with that episode in the show notes. So feel free to look at that and get that printed out if you need a tip sheet to work for as far as food and things like that are concerned. In your experience, Dr. Yassine, what are some of the most effective strategies that have helped your patients with medication adherence, particularly when recovering from a stroke?
Yeah.
And I need to clarify my own question
Yeah,
here.
yeah.
Medication adherence means taking your medications as prescribed.
Yes, I understand. So not just what I've experienced, is what studies have shown. Affordability is key factor, and this is something I have with my patients, the pharmacist, the insurance, to try and cut down on the cost, because I can't be prescribing a medicine that the patient cannot afford. They're not going to take it.
There's
And
no point.
There's no point. Minimizing the number of times the patient has to take it will also improve their adherence. So even in healthy young patients, if you tell them, you need to take this antibiotic for 3 times a day, the fact that they're going to take it 3 times a day is low. And they know this is like short term for a week, for a sore throat or something. And what about like long-term medication? So we have now a lot of medications that come in combination to minimize the pill burden load and the number of times that the patients need to take it. So I encourage these combo medications because it improves adherence. And, for example, insulin, I ask the patient, when do you think is a time that you can take it? Because it can be taken, like the long-acting insulin, either in the morning, lunch, dinner, once a day. And so I don't prescribe it, say, nightly, and I know the patient is going to fall asleep without taking it, and they're more of a morning person. Their routine is easier in the morning, so then I would tell them, take it in the morning. So there are certain medications like blood pressure, cholesterol that have to be taken at certain times of the day, and we just have to adhere to that, having a plan for the patient, outlining it, incorporating it with your pharmacist and all that. Education about their medications, I think, improves their adherence, and knowing why they're taking this and how it's preventing more complications and problems for them.
Yeah. And I want to circle back to something you and I were discussing before. We've talked about how the blood sugar is so related to blood pressure and cholesterol and all of that. And we were talking about how sometimes people may show up as having high blood pressure before they show up as technically pre-diabetic on their hemoglobin A1C, but that may be a sign of insulin resistance.
Yes.
Is there anything you want to say about that?
So, we've known about what's called metabolic syndrome or X syndrome for years. And we know having that increases the risk of cardiovascular disease. And it's a multitude of things. It's blood pressure. If the systolic blood pressure is over 130 and the diastolic over 85, then you're at higher risk. If triglycerides are even within the normal range, but high normal, that increases your risk. Sugar, even in the pre-diabetes range, so fasting over 100, not even a diabetic, increases the risk of heart disease and stroke. Waist circumference, HDL, the good cholesterol, if that's low, that increases your risk. So, as I said, looking at these patients from a holistic approach rather than focusing just on blood pressure or cholesterol, all of these need to be screened, and constantly talking about lifestyle and encouraging the patients to work on that lifestyle to decrease their risk. As we said, that's the most effective means to get to target.
Exactly. And I really appreciate your patient-centered, holistic focused look at each person instead of just isolating it to one condition or anything like that. So thank you for your time today. Your time is so valuable, and I really appreciate you taking it to share your knowledge for free with anyone who's on the internet.
Yeah.
So if you've learned something from this episode about blood sugar and how it's related to stroke, feel free to leave a comment wherever you're listening or if you're watching on YouTube. And feel free to reach out to us at the Norton Neuroscience Institute Resource Center. Let us know if you have other questions that you would like us to make episode about, and subscribe on your favorite platform if it's on YouTube, or if you're listening on Spotify or Apple Podcasts, make sure you're following and alerted so you will be notified the next time we release a new episode. And I'll see you then.
Thank you.